Hi, hello everyone. Okay, all right. So welcome to the show. It is a great pleasure for me to start off this session. So today is a great day for us to discuss a few cases. So this is coming to the season 6 of Dr. Ma's great series of lectures, Cardiac Electrophysiology in Everyday Practice. So the topic of today will be fitness, prowess, and sudden death syndrome. And we aim to discover the risk-benefit paradox of physical exercise and demystifying sports-related sudden cardiac death. With me is none other than Dr. Masud King. He's a consultant cardiologist and electrophysiologist from Loh Gun Lai Specialist Center in Penang, Malaysia, and I am transmitting all the way down south, or rather down from Kuala Lumpur, from Sedang Hospital. Still a busy lab, so it's probably going to be a late night for me as well. So I'll just introduce to you, for those of you who are not familiar with Dr. Ma, he's a great speaker, one of my early teachers. I'm indeed honored to be introducing him, one of my early teachers in cardiac electrophysiology. And he graduated from University Kebangsaan Malaysia in 2002, obtained his MRSP in 2006, and he has various articles on his name. He completed his advanced cardiac pacing and interventional electrophysiology fellowship in IGN as well as UCLA, and he's a certified cardiac electrophysiology specialist and cardiac device specialist under the International Board of Heart Rhythm Examiners. He's also fellow of the Heart Rhythm Society, fellow of the so many fellows. He's also a council member of the National Heart Association of Malaysia. So without further ado, I would like to ask Dr. Ma to present his excellent lecture today. I'm sure everyone will enjoy this session. I will definitely. So on to you, Dr. Ma.
Thank you. Thank you, Dr. Rakib, for the kind introduction. So welcome everyone to the 6th season of EP in EP series, Cardiac Electrophysiology in Everyday Practice. This season is inspired by my media audience. My media audience asked me multiple times, we have seen people suffering from this, sudden death during exercise. Please do one webinar on this. Now, this is my answer to my dear audience. Nothing disclosed. Most tragic and unfortunate events for the past 1 month. Now, these are just the snapshot of the photos that actually I received because they are so anxious and worried to know what is going on here. Actually, a few of them actually walked to me and asked me personally, my colleagues here, because they are very avid cyclists and also they do a lot of exercise every day. They asked me what is going on here. Now, before I'm going to tell you from the perspective of electrophysiology, what is exactly going on here, I am going to ask back my audience here. The preamble, again, is to ask my audience, why do you think people are dropping dead, collapsing during exercise? The first poll, do you think it's due to heart attack? Which, by the way, is by far the commonest answer, both in the lay media as well as in some parts of our scientific community. Do you think it's COVID-19? Because COVID-19 is famous around this time of the year. Sudden death, sudden cardiac death, air pollution, or that is the reason why you're here because you're not sure. Please poll. I can see the trending one is sudden cardiac death. Trailed behind by myocardial infarction, heart attack. So in total, 71% of my audience say that is sudden cardiac death. Very good. Let's move on. in order to answer that question, of course, we cannot plug things from a thin air. We must look at the studies or the post-mortem data on sports-related deaths that is available in the literature. So this particular paper is from the UK. As you can see from here, clearly, majority of the post-mortem data points towards sudden arrhythmic death syndrome as the major cause of sudden death. Now, I want to draw attention to, if you think it's myocardial infarction, then you look at the purple pie, and also the deep red pie here. Coronary atheroma and coronary artery anomalies. These are the two things that maybe you can equate them with coronary artery disease. They are contributing to a measly 7%, and you can stretch it to 10% of all the causes of sudden death in sports-related deaths. This is a series from UK. But of course, we cannot rely on one series only, right? Let's look at the other series from the US, from Italy. US series, you can see here, the US series consists of the upper, on your upper left corner here is US civilian series. You can look at this, coronary artery abnormality, 17%. Now, you couple that with the gray pie bar here, it's going to amount to 20%. How about the military series? The military series, yes, a little bit more, 27%. Now, my colleague always tell me, Ma, you cannot rely on foreign data. You must be loving your own country. So quote your own data. So this is the data that I can find. It's from UITM by Professor Nawawi. I'm sure a lot of you all know him as well. So he and his co-workers actually published a paper back in the year 2018, studying the post-mortem data, autopsy data of 155 unfortunate patients who died suddenly. Now, I want to draw your attention to this. Coronary artery disease was the cause of death at 21.9%, 22%. What is the take-home here? The take-home is, yes, if you choose myocardial infarction as the cause of death or sudden death during exercise, then you're right only a fifth of the time, 1 in 5, the most. Then 4 in 5, there are other causes, not myocardial infarction, not coronary artery disease. Which brings me one of the most important message of the day. Sudden cardiac death is not heart attack. I repeat, sudden cardiac death is not myocardial infarction, because these two things are of a distinctive difference. Sudden cardiac death is an electrical problem, and heart attack is a plumbing problem. Now, don't get me wrong, both problems also pose great danger to the patients, but they actually have distinctive features, meaning to say that they have distinctive management differences here we need to address. Let's look at a case. This case I've been managing for many years. It's one of my beloved case here. The title also, there's a love here. Would love to, but I couldn't. 46-year-old jogger, he's a man. He's a banker by profession. One fine day was jogging and found unconscious in a local park. The witness that saved him actually brought him to the hospital and gave very thorough history, which documented in the notes. Said he suddenly collapsed on the ground and not moving. The public, he's very lucky, happened to be a doctor, one of the medical officer, initiated very high quality CPR, followed by swift transfer to a nearby hospital. Hospital ER recorded initial rhythm as ventricular fibrillation, VF. So he was shocked into sinus rhythm and return of spontaneous circulation. Hence, he was referred to a cardiologist for further assessment. Presenting ECG upon return of spontaneous circulation is this. So look at this ECG for 5 to 10 seconds, and we go for the second poll. What do you think? The patient collapsed while he was jogging. He was so fortunate, so lucky that a bystander instituted very high quality CPR on him and saved him. Now, what is the diagnosis? Normal ECG? You think it's MI still? Yeah. Common. Rib perfuse aborted, so-called. Brugada syndrome, long QT syndrome, or idiopathic VF.
Can you just go back to the previous slide, Ma? Just
sure.
to show the ECG again, yeah.
Yeah. You still have time to vote.
Probably give a full minute for this, just in case
Okay, no
anybody
problem.
wants to see the details, do some measurements, QTC measurements, look hard for epsilon waves perhaps.
Yeah, very good thought, yeah.
Yeah. All right, so we'll end the polling. So it's a tie between long QTS and idiopathic VF. And surprisingly, 21% thinks that this is not surprisingly, 21% thinks that this is a normal ECG. And just one thinks that this is a Brugada.
All right, very good.
Good thought, yeah.
In fact, I didn't expect that. Well, I did calculate the QT interval. It was normal in this case. Actually, it's well within range. It's 450 milliseconds. For kind of information, for men, it's up to 470 milliseconds corrected QT interval. For ladies, 450. So, yeah. So, for this patient, the QT interval is normal. But there's something abnormal here, which is not the ECG. I think the ECG, if I can pull out some abnormality, I could have, but then I think it's fairly normal. But the thing that struck my cardiologist colleague here is actually not the ECG, but rather the blood test here. Well, of course, he did the echocardiogram on the patient. EF was 57%, chamber sizes are all normal. He ran a battery of blood tests on the patient, all normal except troponin T, which is obviously elevated. He did an invasive coronary angiogram, which turned out to be normal as well. So because of the troponin T elevation, the impression by the attending cardiologist was menocarditis. I'll explain what is menocarditis in a while. He was treated with antithrombotic therapy, dual antiplatelet therapy, statin, and beta blocker. He was sent home after staying in CCU for 3 days. Now, let me tell you what is menocarditis. Menocarditis is a relatively new entity which has landed in the arena of cardiology in the recent years. Menocarditis means myocardial infarction with non-obstructive coronary artery. You need to have this criteria here. Of course, MI definition, universal. 2 out of 3, you must have 2 out of 3 of these. Cardiac biomarkers, elevation, ischemic symptoms, either chest pain or shortness of breath, or ischemic ECG changes. And you must have less than 50% stenosis in your invasive coronary angiogram, which in this case is perfectly normal. And there's no other clinical apparent cause for presentation. For example, patient being intoxicated, and so on and so forth. So, do you agree with the diagnosis? The question is yes or no? Very quickly. He has cardiac biomarkers, troponin, elevation. Has he got symptoms? He collapsed. Maybe there's the ultimate symptom. Because if you collapse, then you won't have time to complain to other people of your chest pain or shortness of breath. What about you, Rakib? What do you think? Would you label the patient menocarditis?
I would have probably had probably a cardiac MRI if there was if that was available, I would probably have gone for a cardiac MRI just to see whether there's any changes to suggest things like ARV, or whether there's any any other issues, cardiomyopathy. Troponin is raised, so whether there's any myocarditis and things like that.
Right, sure, yeah. All right, I think the poll has ended. Majority of my audience, 86% say no. They don't agree with the diagnosis. Right, let's move on. Now, before I review the answer to this polling, even before in time to review the answer, 2 weeks later, the patient came really soon back to the A&E with this rhythm. This is ventricular fibrillation. I hope you can recognize this as recognizing Mona Lisa. He was promptly defibrillated back to sinus rhythm. In view of his new VF, the attending cardiologist had decided to do another angiogram just to be sure, and review essentially the same findings. He kept the diagnosis of Minuca the same. What's next? A lot of polling, because I'm going to spend more time explaining about this case, the first case. So I want to get the feel of my audience. What do you think about the management, also the cloud of suspense surrounding this case? Repeating an echo, do a Holter, another angiogram, or implant ICD.
So no one seems to agree with the attending cardiologist to do another angiogram.
Okay, yeah.
Yeah, most of them would consider.
I'm telling the truth. Actually, it was done twice, not 3 times. Done twice, normal. So the third time was not being. I'm not sure being offered, but hope not. But not done. Only 2 times. But 2 times is a lot.
Yeah, it's a lot. Agree. Yeah. So some would want to do. So 30% would want a Holter monitor, another Holter monitoring, just to reconfirm that ventricular fibrillation. I don't know whether what they're planning to see, and I think 70% would want to implant an ICD at this point.
All right.
Yeah.
Majority say implant ICD. I need to again heavily congratulate my audience. You guys are so good. This patient needed an ICD, not at this point, earlier, way earlier. Okay, what is an ICD? Now, when I talk about ICD to my colleague, they always say that, wow, it's something very deep, that only a few people are able to do it, which is maybe right, and they think it's rocket science. It's actually not rocket science. The ICD is a battery pack, like a car battery, combined with very good quality capacitor, combined with a bunch of good quality wires, and with very good quality IC, integrated circuit board. And here comes the ICD. ICD is just a combination of all these things into a small miniaturized engineering technology here. So nothing to fear of, because it's just a bunch of things being miniaturized into a small compact space. In fact, when I explain about ICD, I used to say that majority of us, we understand pacemaker very well, because pacemaker is a pacing device. Its function is to pace the patient, anti-bradycardia. What is ICD? ICD is pacemaker plus. It's a specialized pacemaker, that's all. It's able to pace the patient when the patient goes into bradycardia, but he has extra function, extra utility, as in its anti-tachycardia device. It can pace the patient out of ventricular tachycardia, and also at the same time, because its ability to shock the patient, is able to abort sudden cardiac arrest or sudden cardiac death, if indeed it happened to the patient. So what happened to this patient? The patient at this juncture, second time admitted in the hospital, asked the doctor this question, because he related to me, the wordings here. So he asked the doctor, what happened? Why did it happen twice already? Why? The doctor actually told him that agree at that time, you need an ICD. I would love to do it for you, but I can only do it for you 40 days after your heart attack because I'm a guidelines lover. Aku ikut perintah. So I need to follow the guidelines. I cannot do it for you. Would love to, but I couldn't. That's the title of this case. It begs the question now, from where does this 40-day post-MI rule come about? Of course, you can say that it comes from the guidelines, both European and also the American guidelines. But I really want you all to go into the original paper. They have started it all. What is this paper? This paper is called the DINAMIT Trial. DINAMIT Trial is published in 2004 at NEJM. I want you all to focus on the first word of the title of the paper here, which is prophylactic use. Prophylactic. Now, what is prophylactic? Prophylactic is that you treat the patient before something happens. Prophylaxis means is a paper talking about primary prevention. It never happened. I just want to prevent the first time from happening. That's the definition of prophylaxis. Well, what is the important result, the data that has prompted the guidelines writer to hold on and in a way say that 40-day is a limit is because of this. You look at this graph, the ICD group versus the control group, in terms of cumulative risk of death, there's no difference. P-value 0.66, there's no difference. But how can it be? Because ICD in other trials has been shown consistently to reduce mortality. It's because of this. I always say in multiple conferences, it's simple arithmetic. In a way, not as simple, but the concept is very simple. 1 plus 1 equals to 2. But you plus 1 minus 1 equals to 0. Now look at here. ICD able to reduce by significant p-value arrhythmic death. But in the ICD group also, there is an increase in non-arrhythmic death. So plus 1 minus 1 equals 0. But what is very important to note here is this paper is for primary prevention. This patient is not a patient in primary prevention cohort. It should be for secondary prevention. So this patient should be offered upon his first VF presentation. I mean, you can do a coronary angiogram, but then you must offer already before sending the patient home because the patient already collapsed. Think about it. The patient died once. Just he was lucky, he survived his first death. And the second time he died again, 2 times dying. So when I talk about this case, I always talk with intense passion that in our community, you need to die 2 times before you are qualified for ICD. So ladies and gentlemen, reading journals and papers are good, but please be mindful that we need to read it in the right direction. We cannot read it like here, upside down, okay? It's a double jeopardy here because, ladies and gentlemen, 2 issues we need to recognize here. I still think so. Issue is erroneous application of guidelines and journal publication, which I've told you earlier on. And second issue is, I don't think the patient has menocarditis because the patient received high quality cardiac massage by a qualified doctor. That's why he survived. That would have resulted in cardiac troponin leak. Now, can I prove that or not? Of course, I couldn't because I was not the first cardiologist that managed the patient, but I think highly likely so. There's a huge interplay between duration and intensity. You can have very short duration, high quality, you still get troponin positive. You can have long duration, low quality, no troponin leak. Now, just before you think that that's the end of the case, finish it. This surprised me also. Now, I always want to tell people that I'm not ashamed to tell you that when I look back, I said, wow, really? Look at this ECG. I've calculated for you now the QTC is 490 milliseconds. This is after ICD being implanted. He received 2 shocks. With the shocks prolong his QT, like this is like few months after the shocks already. You can't blame it on the shocks. So this patient indeed have long QT syndrome. Congratulations for those that identified this in the first ECG. I missed it. Now, a black edition alert, although I didn't say that this season is black edition, means that I'm going to tell you something which is very EP. I'm going to give you alert first. The alert coming up. Now, ECG phenotype, when we assess patient whom they have collapsed and revived, resuscitated sudden cardiac death. Imagine you yourself is facing this iceberg. You guys know that iceberg is very tiny up there, but very big down there, right? Now, so you are the guy, at in the small canoe here, looking at the iceberg. At the bottom there, we have this so-called no phenotype profile. You look at the ECG for a patient collapse, resuscitated sudden death. Nothing wrong with the ECG. I think the first ECG fit into that. I couldn't draw any conclusive conclusion on the first ECG. Hence, I actually labeled the patient idiopathic VF. This actually was the indication that I offered the patient for ICD implantation. Idiopathic VF, no phenotype. Nothing's wrong with the ECG. This is the bottom of the iceberg. At the body of the iceberg, really the meat of it, a big chunk of it, I think we need to be humble. Especially us, and more so us, electrophysiologists. There are a lot of subclinical repolarization abnormalities, Purkinje and myocardial foci like PVC, or subclinical conduction abnormalities that we cannot see on the ECG and it's there already, just brewing the disease process. And of course, at the surface, you have a lot of things. Now, I don't mean to flood you all with all these entities, but these are the already known entity. The unknown one still yet to be discovered, ladies and gentlemen, a lot. So what I'm trying to say is idiopathic VF is an entity that can encompass all of this. And when you assess patients whom they have resuscitated for sudden death, you need to look at them in a dynamic way. Don't just look at them at one point in time, but keep on looking at them, investigating them. I mean, don't do repeated angiogram. What I'm saying, investigating, we do ECG. So look for dynamic ECG phenotype to appreciate all these things. And this is really a good paper. I urge you all to go and look at this paper. This is not an original diagram, but then the stuff are really originally from inside. Dr. Mikhail Hasegiel, very excellent, world-renowned electrophysiologist. He say, VF syndrome with structural normal hearts. We are still deciphering or unraveling the mystery. Changes in QRS, QT, J and T waves, or various forms of seen and unseen ectopy. Can you imagine that? There are PVC ectopy or PAC or stuff that you cannot see on ECG actually is there already. All right. Now, what are the implications to everyday practice? You must be able to apply, right? You can't use this diagram, which is, the first look is very complex. How to apply that? My message is very simple. Remember, sudden cardiac death is not myocardial infarction. Remember that. There are two distinctive conditions. When you do high quality CPR, you necessarily cause some troponin leak because high quality CPR compresses down into the cardiac chamber. So you will injure some myocardial cells and hence causing the enzyme to leak into the systemic circulation. We need to realize that ECG phenotypic manifestation can be dynamic in those patients whom have suffered a cardiac arrest. So don't settle with just one ECG, but repeat ECG. You don't want to repeat ECG after every 5 minutes, okay, but you need to every time see the patient, at least do a ECG. You may find something different in each of the ECG. Last but not the least, to my dear audience here, remember. The only proven therapy to improve survivability in patients with resuscitated sudden cardiac death is only one. The only one is ICD implantation. Now, second case, gym time blues. It's a more recent case that I saw. 33-year-old man, no known medical illness, first episode of syncope in 2015. He related to me that happened during exercise in gym. So I'm not sure whether you're into this personal trainer thing, but I have checked on the personal trainer, the exercise profile. I think it's very intensive. He was doing intensive giant set. Giant set means you do one exercise after another, non-stop one, basically. Trainer described that his son turned blue, non-responsive, and started some jerky limb movement. And the trainer, which is actually a trained trainer, okay, tried to palpate his pulse, no pulse. So they got panicked. They did brief CPR 5 minutes. And fortunately, he got revived and appeared okay. Of course, because of jerky limb movement, so he presented to the hospital. They advised him to see a neurologist first. He was extensively investigated normal, including EEG, of course, and various other tests. And he saw cardiologists, extensive and investigated also normal. Chest X-ray, ECG, echo, stress test, coronary angiogram, Holter, all reported to be normal. From 2015 to 2016, he had 5 similar episodes. Most of the time happened when he exited himself. He's really worried now. Now he came to see you for third opinion. Of course, you examine the patient, right? As I always say, you've done all the tests already, no need to do, but except maybe I repeat one, ECG. Now, I want you all to look at the ECG for 10 seconds, and I will pour you all on the ECG diagnosis. Show you the option first, I'll come back. What do you think? Is it a normal ECG? Or myocardial infarction? Long QT syndrome? Or just like the first case, idiopathic VF? Or none of the above? For those choose none of the above, must tell me the answer. No, I'm joking. Okay, he's okay. Let's go back to the ECG. The 33-year-old man, syncope, maybe collapse because the trainer did 5-minute CPR.
I think some trainers would have considered that a success, suffer fast.
Yeah. I need to find out the name of the trainer. If I want to go for personal trainer, I will enroll the same trainer. He's very good. All right, there's a tie here. 40 versus 40%, 39 versus 39. 39% of my audience say is normal ECG, and 39% of my audience say none of the above. Now, I'm not going to ask you, for those who have voted none of the above, what is that? But I assume you know the answer, which I'm going to say, congratulations, again and again. Rakib, I think next time our MHRS session in Enhammer is going to have tough time already. They're so good.
Yeah, they're so good now.
Yeah. All right.
So I think just coming to this ECG, I think, I mean, in my clinical experience, people would just focus on the smallest changes. So those T-wave inversions looks a bit suspicious. So I'm not sure whether, how people interpret this as normal.
Yeah. So simple things first here, my dear audience. Remember, I told you all back in season 3, I think, or season 2, season 3. What is an abnormal T wave? The criteria are numerous. honestly, you can spend 1 week studying the criteria of abnormal T wave. But I remember the other way around. What is normal? The normal T wave is inverted T wave, no going beyond V2 in men. And for ladies, not going beyond V3. So men and women, we are a bit different. This is men. So V3 T wave inversion is abnormal. This is not only the only thing. Behold, lead V1. Of course, it's sinus rhythm. A P wave followed by a normal PR interval and QRS complex. But I want you to concentrate, really concentrate, strain your eyes in looking at the QRS morphology here. Let's talk about normal conduction system, which I have showcased also in the last season. So our command center is the SA node. It goes down to the AV node and it gauges the His and Purkinje fibers and the electrical wavefront spread out, hence inscribing a QRS complex on the ECG paper. So this is a normal patient V1 QRS complex. As you can see here, the downstroke and the upstroke is very crisp, like when you can bite it, it's crisp. It's very fast. What if I tell you now, there is an area of scar tissue in the right ventricle? Because the area of the right ventricle got scar tissue, they will have slow conduction there. So you have electrical wavefront coming down, flooding all the myocardial cells, but then those that scar tissue will get depolarized slower. It's like everything else left the bus already, still left 2 people on the bus. This is a small green arrow here. The big green arrow is the normal conduction, a small green arrow here. What will happen then? Of course, you still inscribe a very crisp downstroke and upstroke because majority of the myocardium is still healthy. But lo and behold, because got 2 persons left on the bus, they have late arrival. Hence, they will cause another bump. Not enough to cause another QRS complex, but a bump at the end of QRS complex. We call it the epsilon wave. If you can remember, the epsilon before E is D. D is delta. Delta wave is in front. Epsilon wave is behind. So delta wave is called pre-excitation and epsilon wave is called post-excitation. It's like every myocardial cells in the RV already depolarized, left about few, then that is inscribed an epsilon wave. Why V1 then? You must ask me. Why? Because V1 is the lead that look directly from the front into the RV. This is the lead that look directly into RV. That's why epsilon wave is best seen in lead V1. We did a cardiac MRI on the patient. The MRI results showed RV dyskinesia with regional akinesia. RVEF was 35%. I think Rakib is expert in this also. Rakib will agree that this is a major task force criteria to diagnose a condition called arrhythmogenic right ventricular cardiomyopathy, ARVC. So this patient finally got implanted ICD in 2017. He received 3 appropriate therapies so far. I'm still following up the patient. Of course, my audience will ask me, for this patient that collapsed or fainted in a gym, would you still advise him to go to the gym or not? The answer is yes and no. I told him, look, you cannot engage in competitive sports anymore. And that includes giant sets in the gym. Why? Because you're pushing yourself too much. By saying competitive, I used to tell my audience or my patients that I don't mean winning the trophy, you know. I mean challenging one another to achieve a higher exercise goal. You can do leisure exercise. I encourage him, please do, be happy about it, do exercise, but just do leisure exercise, but not competitive sports or competitive exercise. There is a peculiar relationship between risk of dying and mortality risk, and exercise here, ladies and gentlemen. If we don't exercise at all, 0, down here, our risk is high. But good news, How can it be good news? High risk. Good news here, if you exercise a little bit, the risk drop exponentially down. Until, of course, you exercise more, the risk will drop further, until a point of nadir. Means that the more you exercise, actually, the risk reduction is the same. In fact, if you exercise beyond a limit, you increase the risk back to a level which is not the same as zero exercise, but to the level of more or less moderate or leisure to moderate exercise. This is a paradox of risk and exercise. I call it the strength duration curve of exercise and mortality. Implication in the everyday practice. I have several messages here for you. The most important one is I want you all to recognize this. Every time, if a patient complains to you, doctor, I fainted during exercise, red flag, the most red flag of all. It cannot be. It's not physiologic. If it's physiologic, it cannot be. Why? It contradicts survivability. Imagine our ancestors, few hundred years or 1,000 years ago, being chased by a tiger. Now you are running, you are exercising because you want to run from a tiger. And halfway running, fainted. You'll be eaten by the tiger. And your gene won't pass down to the next generation. So it contradicts normal physiology. Syncope during exercise, red flag, investigate. Now pay attention to seemingly normal ECG. If a patient presented with syncope during exercise, please at least look at 3 areas here. I start with the bottom. Number 3 is pathological Q wave. All of us, we are trained to look at that. So in fact, there's no need for me to be able to point here. Number 2, fragmented QRS. Means that look at the QRS, whether it's crisp or not, the downstroke and the upstroke. Any additional components at the end. If so, maybe you're looking at epsilon wave, especially at lead V1. And appreciate the strength duration curve of risk and exercise volume here. Because I used to encourage my patient and also all my colleagues that there's no need for us to do very, very strenuous exercise in order to reap the benefit of exercise from exercise. In fact, if you do extreme exercise, the risk will start to come up again. But I'm not saying it's going to come out high. The risk of doing strenuous exercise is still lower than not doing exercise at all. So we need to recognize this. I'm not sending a message that you cannot do very, very heavy exercise, strenuous exercise. I'm just saying that if you want to reap the benefit, get the benefit of exercise, a little bit exercise and beyond goes a long way. Now I want you to look at this video and notice that there's one man here in the middle of a football game just suddenly decided to go to sleep. For those of you all cannot catch this, I'm going to scroll back for you to see again. Okay, I want you to count together. 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds, 7. 7 seconds, his legs moved, and within few seconds later, 5 seconds later, he woke up. What happened to him? His name is Mr. Van Loo. He's a professional soccer player. He has a condition called hypertrophic cardiomyopathy. Implanted ICD. While he's playing games, he suffered a cardiac arrest, sudden cardiac death. And the ICD able to kick in and save his life. The time to action of ICD is how long? You all counted together with me, 7 seconds. Now, I want to ask you all this question. I ask many patients, many of my colleagues, and also sometimes I ask my patient. If the patient currently a patient that had risk of sudden death, going to have developed VF, is in your ICU. You are the ICU in charge. He's lying in the bed. Let's see you're looking at the patient now. He developed a VF on front of you. What is the time taken for you to set up everything in order for you to shock the patient out of VF? I'm sure the answer is more than 7 seconds. Maybe 15, more, maybe 20 seconds, if you're efficient enough. But 7 seconds is very fast. Time to action. No chance for the brain to suffer from injury for any other internal organs. Now, I'm nearing the end of my season 6 here. The take home here is very unconventional and very cheeky here. In fact, the take home I'm going to ask Dr. Rakib. Rakib, what do you think about take home? What is this, Rakib? Fuel gauge, fuel gauge. All of us, we drive a car, we know, right? Rakib, can you tell me what's the meaning of E,
For males or females?
No, I mean, no, for cars.
I mean, females usually definitely won't let the needle go.
Okay. E, okay.
They probably fuel up at the tank sign. But anyway,
Sure.
E is for empty. And
No, I mean, there's a meaning to this joke. So I was in a conference and people say that E, of course, is empty. F means full. But say, some of us, we think that E is enough. F is finished. Now, I want to ask you a final poll here. Now, you're off on a road trip for a great family holiday. Which method would you prefer? You want to fill up your tank first, I call it leisure fueling, or you want to wait for it to drop until E in this case empty, and then you have emergency bottle fueling. Like you run to a gas station and just fill it up and then run back to your car and pour into the gas tank. Which one do you prefer? I'm surprised that someone is voting emergency bottle fueling. There are 5% at least. Okay. There's meaning to this polling. So please poll. Yeah.
It's not many risk takers in our attendees.
Yeah, if you want adventure, then you will have this emergency bottle fueling, which is, I've done it, I must admit, I've done it a couple of times. Unknowingly, the fuel tank is empty, which is not fun at all. Huh? My friend was laughing at me, pulling my leg. Okay, 93%. We prefer leisure fueling. Means that you fill up the tank first before you go for a family holiday. Which is rightfully so, ladies and gentlemen. Think about it. If the patient already suffered from one sudden cardiac death, successfully resuscitated, if you don't implant an ICD, you are hoping to get opportunity for emergency bottle fueling. Why? The patient may come to present to you another VF and you need to be in a hurry to shock the patient. This is emergency. You are not prepared. If you implant an ICD, you already get ahead of managing patient. The time to action is how long? 7 seconds. The patient will be shocked out of the lethal arrhythmia into sinus rhythm. Of course, you still need to treat the patient, see the patient, but this is much, much kinder to the patient. Just think about it. It's not so much for us. I mean, the guidelines say we should class 1 indication to implant ICD, but just look at the adoption of ICD in our community. So I will end by showing this as the message of the day. So I hope you all enjoy this season. This season is talking about device. There are more seasons on devices to come, more to talk about, which I call it the 5 indications of you think you need to put in a pacemaker, no need to put a pacemaker, and another 5 indication of you think no need a pacemaker, in fact, the patient need a pacemaker. So please stay tuned for future season. I really thank you all so much for the love and the support you have shown to me and my team for the past 5 seasons. And please continue to support us and send us our feedbacks on future season contents. We'll try our best, to tailor to your needs. Back to you, Dr. Rakib. Thank you.
Thanks, Ma. I think